by seeing the video that we're posting at cardiaccarecritique.com, and it's the videos from WFLHCA. So I'd like to welcome you this morning for our mystery case. And our theme today is Show Me the Grafts. Show me the grafts. And so we have a gentleman who is a 63-year-old, and you can't say he's not a rocket scientist, because he is a rocket scientist. He's not a brain surgeon, but he is a rocket scientist. And actually, my dog Beaumont met him on the corner of Swan Avenue and Snow, and we were out walking, and we came across this gentleman who admired the dog and started talking, and then told us about his automatic defibrillator and a couple other things, and we said, you need to come see me. So he became a patient, recruited from, I'm not that desperate, but I met him on the corner, and he said he wanted to come to the office. So he basically is retired as a rocket scientist for NASA and certain programs that are secret. And he has traveled around the country, traveled around the world, lived in Washington, D.C. before he moved to Tampa, and apparently was in good health until at over 300 pounds at the time, he had a sudden collapse, and was a very difficult transport by EMS to Georgetown Hospital. I think there was a doctor on the street as well. And so there was some resuscitation efforts, and he showed up there and had emergency 3-vessel bypass grafting, and ended up somewhere along the line, we don't have all the records, with the 15% ejection fraction. And so he also later that same year had an ICD installed and then had that replaced in 2012. At present, he denies any symptoms. He's not having chest pain, shortness of breath, palpitation, PND, peripheral edema, lightheadedness, and so forth. He does have weight loss in that he has lost considerable weight since that event. It hasn't been something unnatural. He actually has worked at losing the weight. It's not related to any cardiac disease or other underlying disease. It's interesting that he has no symptoms with an ejection fraction of 15%. And you ask yourself, how can that be? Well, we had a gentleman who had ejection fraction of 12% who was able to bike Davis Island here in Tampa, and he would go the whole circumference of the island without any problems at all. And so what it turns out to be is it's the LVEDP tells you how much someone can do. And so if you have a high LVEDP, you'll have a high wedge pressure, and you won't be able to do any of those things, and you'll have PND, orthopnea, pedal edema, and so forth. But if you have a low LVEDP, you're okay. And so the ejection fraction is sort of a stand-in for us for the LVEDP, and it's not a very good stand-in. So everyone says, well, what's your ejection fraction? Oh, you can't do much. Your ejection fraction is 15%. Not true. The real question, which we can't answer because we don't measure it non-invasively, is what is your LVEDP? Tell me what that is, and I'll tell you how much you can do. So we're using the wrong marker because we don't have the other marker. And so we'll find out more about this gentleman. And I'm going to ask some questions, and let's get to the next part of the story. And so obviously he has coronary artery disease, 3-vessel bypass grafting. He had to be a smoker, 2.5 pack years. He quit 29 years ago. Great tribute. After that event, he quit smoking. He does regular exercise, but no special diet. There is a family history of heart disease at an early age, and his father at 55, who died of a heart attack. This gentleman would have died too if he didn't have resuscitation and wasn't in the middle of a city where he could go get bypass surgery immediately. He's on just a few drugs, an ACE and statin. He's not on a beta blocker right now. I'm just seeing him for evaluation of what medications he needs, and we'll make some more decisions. Heart rate is 56. That's convenient. Blood pressure 120/76. That's nice if we're going to be treating him with other medications. It's nice to have a good blood pressure to work from, and the heart rate is not uncontrolled, so that's a good thing too. what to do next, and we don't have our loyal Pooh today because she's got an emergency cardiac cath and can't be here to play the straight man and be part of our Socratic discourse. And so I'm just going to move on to the next part, and we'll show you an EKG. So this is his EKG, which shows a normal sinus rhythm. And I have a little arrow here that shows the PR interval is stretched a little bit, and it may be 0.20. So at this heart rate, which looks like a sinus bradycardia, about 60 or so, actually less than 60, 50, 55, well, we'd have to say that he has first degree V block. And he has a QRS that is has a T wave that's discordant, and there's poor R wave progression, which may be a sign of his apical MI that he had. It's usually thought about as being septal MI, but MRI confirms that it's usually apical, not septal. And but there are abnormal septal forces in that the septum depolarizes from left to right, and in this case it's depolarizing from right to left. So that's abnormal. I know he has an ICD. I don't know if he has a pacer, and so I don't see any pacer waves or spikes on this EKG tracing. And then I don't see any other obvious abnormalities. So it looks like there's a big Q wave in AVL, and so and there's poor R wave out in the lateral leads. So you might say he's had a septal MI. He may have had a lateral MI. No evidence of an inferior MI. No evidence of posterior MI. So it is consistent with coronary artery disease. So let's go to the next slide. And now what to do next? And we're not going to discuss that without a resident to bounce it off of. But we do have an echocardiogram, and let's take a look at that and see what that tells us about his heart. We're going to get that up. Okay, we're on the mic again, and we see his left ventricle with very poor contractility, generally speaking, and it doesn't move as fast when we transmit this, but you can see that the septum is abnormal, the inferior wall is abnormal, the posterior basilar part of the left ventricle is abnormal, and so at least, and some thinning of the septum. So you get the idea there's LAD disease, the apex doesn't look too good, what we see out here, and you also get the idea there's probably some right or circumflex disease, so we're getting multi-vessel coronary artery disease. And then you can see the valve is opening real nice on the aortic valve. You can see some of his diastology rolled by, and then abnormal septal motion seen in the ice pick view of the left ventricle septal posterior wall. And then we've got a short axis view, which again shows some dropout of the lateral wall, that again the left ventricle is not squeezing well, and the septum and the inferior wall that we see well as the anterior wall up front there. And so it looks like it's the same rhythm that we saw before and the same conduction defect that we saw before. The aortic valve opens very nicely. Left atrium is a little bit enlarged, which we would expect with somebody with this degree of left ventricular dysfunction. TR is not very prominent, and his RV systolic pressure was somewhere in the 12 range, plus 10 gives us 22, and so he does not have RV systolic pressure elevation, which goes along with what we said, that he's able to exercise quite admirably, and that means that he doesn't have elevated left ventricular diastolic pressure, so he doesn't have elevated right ventricular pressure as well. So there's no backward failure. So this is more of that. This is RV systolic pressure, maximum peak gradient 22, and 32 when we add 10 for the right atrium, and so not elevated. Less than 35 is normal. And again, showing the same ventricle, there's little mitral regurgitation, not a lot, and I think we've seen pretty much all. And roll through, and we'll switch back to slides. So now we're coming down to, we don't have a coronary CT, but we're going to show some other cases to talk about that and to see where we go with this patient. And so the patient is scheduled to have a coronary CTA. And when do you think patients post-coronary bypass grafting should have CCTA to look at the bypass grafts? That's the big question today that we're going to address. And I've addressed that question at one time, a long time ago, when we were doing coronary bypass grafting at Tampa General. And I did a study of 77 patients, and within a month, within 30 days of having bypass grafting, because I just wanted to know what kind of results we were getting, because how could we recommend the test without knowing the results? This was in the 1970s, and so we didn't have coronary CTA to help us, and we had a 15% occlusion rate at 30 days. Well, that wasn't very surprising to me. I remember seeing a patient that was transferred from Lakeland, and I got a consult an hour before cardiac surgery to see a patient that came from another hospital to Tampa General. And I looked at the cine angiogram, and the patient was not operable. He had severe multi-vessel diffuse disease, tiny little vessels, some little collaterals, and it didn't look like there was much promise. It was after nitroglycerin, so the vessels were maxillary dilated. And so I went to find the surgeons, and they were in the cafeteria having lunch, and I said, this patient's inoperable, and they said, he's already on the table, we were going to do him. And so it wasn't much of a consult from me if the patient is a fait accompli. So he did have his surgery, and he was one of the 77 that we studied, and incidentally, all of his bypasses were down. They were all occluded. So this is all comers then that we found a 15% occlusion at 30 days, because they weren't patients that were low-hanging fruit that were basically selected to be good candidates for bypass surgery. They were just all comers. So that doesn't sound very good if you got 15% occlusion rate at 30 days. I'm sure we've improved a lot since then, because these were primarily venous grafts, not arterial grafts. And so I think the numbers we were quoting back then also were a 60% patency rate of vein grafts at 10 years. So 40% down at 10 years and 15% down at 30 days. So we're not going to answer that question until next week, and we'll show his study. Because he's in the process of pending insurance approval that you're also familiar with. So let's go to some cases to see what we have in the way of supportive information, both from the literature and from our own cases. So this time we took a patient that we have 17 years continuous follow-up, which is certainly very unusual in academic medicine. We've discussed before when we presented the lady with 40 years follow-up that in academic medicine, follow-up is not continuous because our professors have to move and are nomads in order to get promoted. So you start out as an instructor, you make your way to assistant professor in another town, you go to another university, you're associate professor, and you work your way up to being professor and then chairman. And going through that process usually requires you stay at one place 5 years and you move. And so finally, so you're not going to be able to follow up on any particular patient yourself personally for any length of time beyond 5 or 6 years. If you stay in one place, you're doomed to forever be an associate professor. So basically, to have this kind of follow-up and present it in an academic setting is extremely unusual. And one of the cases we'll present will be our 31-year follow-up on a cardiac transplant patient who's one of the longest follow-ups of a living transplant patient in the world. So we'll show that to you one day. So this particular patient, you can see, we can also decide whether all this stuff that we did was of help or not. Here's a cardiac cath in 1999, main left disease and 99% right coronary disease. And so I think the ejection fraction was pretty good at that time. And so this is a patient that is basically 10 out of 10 cardiologists will agree that he needs bypass grafting. So and it's some risk associated with cardiac cath. Some risk associated with cardiac cath in these patients because of, one, it's almost occluded right coronary, and then if it's ostial main left disease and you're injecting dye in the ostium, you can put the catheter in there and jam it, and so that's no flow in terms of blood carrying oxygen, and then it's injection of a toxic material that's contrast with no oxygenation, which can result in electromechanical dissociation. And it's the most common cause, has been in the past, of death in the cath lab is ostial main left disease. So it's feared by everyone. So he went on to get bypass surgery, had a lima to the LAD, saphenous vein. So it'll be interesting to see how long-lasting these vein grafts are over a 17-year period. And so he had some Spect scans. And so this is a stress rest image of his cardiac Spect scan, and I won't belabor the point on this one, but he's a very heavy guy, and he's got diaphragmatic attenuation or stomach attenuation of the inferior wall, and you have to look at other images to understand this. There was some right ventricular uptake, because here's the point of the insertion of the right ventricle to the septum. So you can see that's kind of thickened up there, and it looks like some right ventricular uptake. To make any more out of this test requires having the cine mode that you can watch and watch the acquisition during the cine mode as it revolves around. And so I don't have that to show you. All we have are these kind of static images, which are of no value to you, but you can see there's some resting abnormalities, and they don't really go away with stress, but that was diaphragmatic attenuation. And so he did have coronary CTA, and as was the practice in those days, calcium scoring was very common, and so obviously there's no use in calcium scoring somebody who's had bypass surgery to decide about the risk of heart disease. And but the radiologist put that in the package, and that was part of the things that were being done there. I've got static pictures of his CTA then. His bypasses were all patent at that time. And so that was 2005, which was 5 years out, actually 6 years out from his bypass surgery. All bypasses were patent. You can see the calcification in his main left coronary artery down there, which is highly correlated with main left obstructive disease as well. There's a lot of prominent calcification down there. We do have some static images of his old CT scans because we keep all those in notebooks so we can have them for comparison. And it's really interesting now we're getting where we're 12 years out from our first patients that we did coronary CTA, and we can compare today to 12 years ago on the same patients, which can be useful. So we do have a CMR that he had recently. Back to our pictures again one more time where we had our table. And so here's back to our table. Let's just go down our table. Coronary CTA, we had images from 2005, and they looked okay, and grafts were patent. Spect scan, no reversible defects. CCTA, 2005, occluded lima. There was a string sign on the lima, and so it really wasn't in the LAD, and it didn't look like a lot of runoff. And so we were thinking the lima didn't look so good. We can look and see what it looks like now, but it didn't look so good. And then a less than 50% lesion, the saphenous vein graft to the OM3. So there was some disease that was taking place in this particular graft. And there's probably some endothelial proliferation. There was a PET CT, no reversible defect. Another PET CT, 2009. Went from 50% ejection fraction at rest to a 70% ejection fraction during stress. That's an expectation. If there's a drop of 12%, that frequently is correlated with main left coronary artery disease without revascularization. PET CT 2009, 54% ejection fraction to 53%. So something came up that we tested him again the same year. And then PET-CT 2010, no reversible defects, increase in ejection fraction. Here's a fall in ejection fraction of 7%, no reversible defects. That's not significant. Here's an increase in ejection fraction on CMR from 56 to 66%. That's kind of normal, but there's some reversible mild or mid-apical anterior lateral ischemia, which we're going to show. So hang on here and we'll show you that. Yeah. So this is a lot of data that we loaded, and we can double-click this and make it bigger. And there it is. And so this is a black blood image. We want to use this conference to get you familiar with cardiac MRI. Looks like we got the Largo group up, and actually it looks like you might be on a mic. I don't know if you can speak or not. Hello, Melody Largo group. Dr. Rajendran, you guys there? Don't hear from you. Okay. Well, let's go on. We'd like to have a fellow to talk to. And hang on, please. That would be great. So we're looking at the left ventricle in the black blood image, and I don't see an infarct. It looks really nice. It looks like nice thickness. And this is the interatrial septum. This is the left atrium, right ventricle, left ventricle. Mitral valve. We can actually see some of the coronary anatomy. This is the main left coronary. Here's the right coronary. Here's the left anterior descending. Circumflex is going to come along here. There it is. There's the circumflex. There's the moderator band in the right ventricle. Pulmonary artery. Aorta, descending aorta, beautiful image. Liver over here. Here's the stomach coming up, stomach bubble. That's why you had the diaphragmatic or stomach attenuation that you saw on those old Spect scans. It's got quite a bit of subcutaneous adipose tissue. Pericardium looks good. Here's the pericardial line going around there. No pericardial fluid. Doesn't look like he has pericardial changes post-operatively that would cause hemodynamic abnormalities. So very, very nice images. Here's the trachea, the carina, the esophagus, a little air in the esophagus down there, sternum, spine. So let's take a look here, and actually we'll see some motion. It's going to go in the other way. So I think you saw the heart beating backwards there for a minute. Doesn't really do that. Now it's beating forward. It looks like nice contractility. It looks like left ventricular hypertrophy. Definitely someone who's been hypertensive. No significant mitral regurgitation. Nice left ventricular contractility. And we continue. You can even see the little chordae tendineae on both sides, tricuspid valve and the mitral valve. I always judge an MRI study and a CT as well by being able to see the chords. If you can't see the chords, you don't have a good study. Here's the aortic outflow tract. No evidence of hypertrophic subaortic stenosis. Here's the aortic valve. No evidence of aortic stenosis. So far, so good. So you can see the pulmonary veins entering the left atrium, and you can see blood wafting in. These are very pretty images, and by the way, this is without contrast. This is what you see without contrast. This one has got the heebie-jeebies, and so we'll move beyond that one. And here's a good one, watching the force, the velocity of flow through the aortic valve. We can actually measure that just like you do with the Doppler with ultrasound. and you can compute the valve area. We can do the exact same thing using phase. And so that's another one of the remarkable things about MRI. It's also interesting that with MRI, we have more than just the 4 windows you have with echo. We have any window we want. We can go perpendicular to anything we find. We can make any window that we want. And so having universal windows ad infinitum makes it very easy to line up with the aortic valve and get exactly perpendicular and then exactly looking into it. And so we've actually used echo techs to train MRI techs because of the parallelness in the 4 images that we use all the time in echo. But then we have additional images with MRI, which the echo techs love that. We're watching the right ventricle squeeze. This is unusual. You're not used to seeing the right ventricle in this particular view, which is a sagittal view. And you can see the pulmonary valve up here. We've got a tricuspid valve in here somewhere. Very interesting images here. Pulmonary valve. This is where we do a short axis, and we keep moving up the short axis from apical to mid to base. We can use this for the most sophisticated ejection fraction, which is the gold standard for ejection fraction. This is the gold standard. So it's very useful in patients where we need to have an exact ejection fraction, such as cardio-oncology patients who are receiving potentially cardiotoxic chemotherapy, where the ejection fraction can make or break whether you continue chemotherapy or not. These are phase images. This is our Doppler. We know exactly what we're looking at, and we can superimpose them, and we give you information as to velocity of flow, which then can be used to calculate orifice size. And so we superimpose phase on images and then use that information. And this is a contrast study. Contrast studies are such that we like to turn it down so the contrast isn't too bright. And we like to look and see, we do the stress first. We like to look and see that there's some abnormality that's occurring over here. It looks like inferior lateral decreased flow subendocardially. This is a Lexiscan stress image, dynamic, with contrast, which is gadolinium. Can't use that if people have severe renal dysfunction because of the dermatological fibrosis that's induced. So we always check the creatinine. This is a resting study, more resting studies. Let me stop this one for a minute, and we'll move this back. Okay. The apex has a little decreased, a little thinning down there. We're looking for late gadolinium enhancement of an area of scar, and actually we're looking at through a whole bunch of slices. So as we go through those slices, we've nulled the left ventricle. And if there's contrast that's gone into the extracellular space, it will identify scar tissue and it will become very bright, like this over here in the left atrium. It will become very bright. As a matter of fact, this has been used for left atrium, left late gadolinium enhancement, for finding the substrate for atrial fibrillation and deciding if that substrate might be ablated or not. And so this looks pretty good. And so this is the same thing where I'm looking for late gadolinium enhancement. And it should be very bright like up here, but that's in the base and it's not the right place. We should see it somewhere along here, very, very bright area if there's scar tissue. It would be as bright as this area over here. And so we're looking for that. We've nulled the left ventricle. We've nulled the right ventricle as well. I don't see any scar in either one. And this is not the right area for scar. That's because we're getting into some of the mitral valve annulus in the base. And so that looks good. So we have no scar tissue that we've identified. We have identified an area of ischemia, and we're interested in understanding that. So let's go back to our slide presentation. So this gentleman has had shortness of breath on 2 occasions. He's very heavy, and he travels to North Carolina and back, and he's not extremely active, but when he got atrial fibrillation, he became very short of breath, dyspnea on exertion, and pedal edema. And that made me think that that thickened left ventricle needs that atrial kick in order to resolve the issues of left ventricular filling. And so I concluded there was diastolic dysfunction. He needed to have sinus rhythm, and an atrial fib was very poorly tolerated. And so we actually sent him to be ablated. He had the ablation, went back in sinus rhythm, and felt great. And so all of a sudden, again, he's reverted to the same symptoms where he can't take the garbage out, which is his greatest activity. He has new shortness of breath, dyspnea on exertion, and no atrial fib. So this should be a reason to go looking for something, because it's not normal for this gentleman, and he's complaining quite a bit about it. So at this point, show me the grafts. I'm interested in seeing what his grafts look like. Looks like there's some problem with some graft, given the MRI showing some perfusion deficit in the inferior lateral, inferior area. So I won't be surprised if there's a graft problem. So as you can see, he's got a grainy image. That's probably is an expression of his 280 pounds that he has. But as we go through this grainy image, and you see he's got a lot of deposited subcutaneous fat, we see here's a bypass graft. So we see one right away. We see another one that over here that stops. No question about that. Contrast density. We can get the contrast. Hounsfield units. We're going 440. We're going 425. And then 2. And so there's no question that's gone down. So we got a back to this. Looks like on the right side of the heart, right side of the aorta. So it looks like that's probably going to a right coronary, would be a guess. We can find out more here in a minute. Let's go see what else we got. Well, let's see if there's a lima. We're missing a lima. See, here's the rima. So they didn't use that. There's a lima missing over here on this side. So he must have had a lima that was used, and it looks like we can probably pick up on a lima over here in a minute. There's the LAD out here. We should see a lima tapping in here somewhere. Hard to find, but let's go over to the volume rendered images and see if we can have better luck. Get rid of this, and let's expand on this. Well, this is pretty obvious. Right coronary bypass graft gone. And here's one that was pretty complicated that came around over here and picked up the circ. It looks like a marginal vessel of the circ. Big bypass graft. And so here's the markers for the lima. and you can see where the lima has had little clips that are put on to knock off the side branches that mark the interthoracic vessels or the intercostal vessels. So to get the blood flow going continuously down the lima and not supplying the thoracic cage, little clips are put, not as really markers. I use them as markers, but the clips are put there to knock off the interthoracic, intercostal vessels that go underneath the ribs. And so the clips sort of go up to here. They're going the right direction that you would expect from the lima, but there's no lima. We can try to poke on it and see if anything wants to show up. And nothing's showing up in there. So that lima, and then we can go over to the mid-LAD and see if we see that. And then we can triangulate it too if we want to. So the mid-LAD, here's the main left. There, you can actually see the main left disease. There's severe proximal narrowing of the main left. And then here's the LAD with calcification. And then here's more calcification in the LAD. And the lima should be coming off right in here. And there's no lima. So that would explain maybe some of that apical thinning that we saw. There must be some collaterals to the LAD. But the most recent problem looks to me like it's going to be the absence of the bypass graft that goes to the right. And that would explain his new symptoms. And so we can look over here and try to triangulate this. And there's our present bypass graft that's going all the way over the circumflex. Well, that had a long way to travel. And then the right missing bypass graft is this one right here. Watch. And there's the missing bypass graft. And then to look at the native vessels is very difficult because in this gentleman, you can see how obvious the bypass grafts are. And that's why you have a 99% sensitivity and 99% specificity, which what in medicine has those kind of odds of being able to identify stuff? There's nothing else. If we were going to look at the LAD, which we can, which we'll put over here, hang on, it's not going to look so great in this picture. And you can see we really can't tell a lot. There's contrast coming down here, a lot of calcification, but the image is so we would need to have a computer clean it up and get rid of this noise. And or we'd have to use a lot more contrast and a lot more KEV, maybe 140 KEV, and we'd have to do a lot more to be able to see this. So not looking good for understanding this vessel, but that wasn't our mission. Our mission was to look at the grafts. We found the graft that's important. And I think this gentleman, we're going to have to see his coronary anatomy if there's something we can do for him with his right coronary artery. And that would involve coronary angiography because I don't think we can have a very good understanding of his right coronary artery from these images. And so we can see what we saw with the right. And let's take a look. And we'll make this bigger. And we'll look at this over here. And that's a bypass to the circumflex, and the computer labeled it as being the right coronary artery. It's not the right coronary artery. So we can't count on that. Here we go. Here's the right coronary artery, which the computer labeled as the circumflex. And you can't see a lot about that. All you see is a bunch of calcium, and then you see there's some contrast dribbling around. So if we were going to do angioplasty in this gentleman to reconstitute flow to a vessel that had a bypass that's occluded, we may be dealing with a chronic total occlusion here. We may have to use one of our chronic total occlusion experts. We do have William Lombardi, who's in Seattle, who basically is the world's foremost chronic total occlusion expert. And then we have Dr. Heuser in Phoenix. So we have people that specialize and chronic total occlusions. If we were going to do something for this gentleman who is having shortness of breath since he occluded this vessel, we would have to consider that. So let's go back to our slides, and we have seen the grafts. Show me the grafts. Case 3 is someone who has archaeos. Archaeos, racheos, I guess racheos, or arachos is basically a right anomalous coronary artery from the opposite sinus of Valsalva. He also had critical left main coronary stenosis, 95%, approximal OM1, and he got bypass grafts with a LEMA to the LAD, a saphenous vein graft to the PDA, and this time a REMA to the OM1. These REMAs and LEMAs, free REMAs, radials, usually have a patency rate at 10 years of 95% or greater. So we trust those vascular grafts that are arterial much more than we trust the ones that get the endothelial proliferation, which are the saphenous vein grafts. We can look through here and see he's had some scans in the past, had CT, they did a calcium score, which was kind of stupid, but that was done in those days. In 2005, he had a CTA that showed some of his lesions and some of his grafts, and there was some narrowing, approximately 1/3 of the saphenous vein grafts to the PDA. And you can see we weren't reading very well in those days. Greater than 50% LAD, greater than 50% right. Here's PET scan, very reliable. PET scan again, very reliable. And coronary CTA, we're going to show you some images. Okay, so we've got a gentleman who we purported has a coronary anomaly. Let's look and see. So there's the right coronary coming off from here. Look at that. There's a coronary anomaly. So just like we said, he does have that. And it's the right coming off. Here's the main left. Here's the right coronary. It looks like it does have a subintimal course right there. It's coming, actually it's coming off of this sinus of Valsalva right there. And so, but he's not at risk of sudden death from that growing up because he never played sports. And so he became a lawyer and didn't actually get involved as a competitive athlete. And so he really wasn't at risk. And you can see the right coronary artery coming out this way. And there it goes back there. But let's go look at his grafts. And the easiest way to see those grafts, as we showed before, is the volume loaded image. So let's look at the volume rendered image and see what that looks like. And here we go. So this is nice. Here's a saphenous vein graft that's going to the PDA. It gets smaller as it gets there, and it's pretty big in the middle. That may be somewhat ectatic, or maybe this has had some intimal proliferation, and maybe this has had intimal proliferation as well, just right down in there. And then there's the native vessel, and so that looks like that's would be considered patent. And here's the right coronary artery, and you can see some lumpy bumpiness, and then you see some stenosis in there. The right coronary artery, as you see, has an origin, runs between the aorta and the pulmonary artery, so it's going anteriorly, and then you can see it going back where it originates from the left sinus of Valsalva. So, hey, that's a nice coronary anomaly. Perhaps this is where there was insertion for the Sarnes roller pump, where you have to put cannula in, and that may be where a cannula was, or it may be where a cross clamp was. And so you see a little area on the aorta. And then we come over here, and there's a saphenous vein bypass graft trailing up like that. Excuse me, there's an internal mammary that's trailing up here. Looks kind of skinny. You could actually look at it if you want to. So let's go look at the IMA and see what that looks like. Yeah, there. You can see it pretty good coming down. There's a clip over here, and it's coming down to the left anterior descending and filling the left anterior descending, and it's smaller than the LAD. And then let's see if there's another graft over this way. Let's take this off. And see if we see any graft going to the marginal here. We may have to scroll through to look. So let's go over here and scroll. And there's the origin of a graft that goes to the right. And there should be, and there's the, we see we're missing the rima and we're missing the lima. So there's a rima around here somewhere that's going to a vessel that's very small, the rima is. So we have to hunt and peck for the rima, but there's a rima in here somewhere that's going to a vessel, and then we've got the lima. And so the rimas usually stay, they usually stay so you can see them quite well because of the high patency rate. I can't find this one right now. And then this is 2010, so it's 6 years ago. Patient is still doing well. And so I suppose he's still got patent grafts, although there's no correlation really how well somebody's doing usually and the surprise of finding a bunch of grafts down. Perhaps because of the medications, the beta blockers, and the sedentary lifestyle of a lot of our patients. So there's a rima somewhere, and we'll hunt and peck. This patient we have is a gentleman that's a new patient to me who had an anterior wall mine, bypass grafting, a lima to the LAD, saphenous vein graft to D1, saphenous vein graft to the circumflex, and saphenous vein graft to the right coronary artery. And he had PCI to the LAD, diagonal into the OM1, and an ICD placed. And he's had recent observations by us because we've recently got involved with him. And he's had a coronary CTA. If you hold on, we'll show it to you. So let's go directly to the volume rendered image and see what we can see here. And so here are grafts. And so let's take a look at what we have and what we can say about it. So here's a graft and a marker, and it looks like an end to that graft. It just pokes out, and that's it. And that was a vein graft. And here's another vein graft that just pokes out, and there's nothing there. And so 2 grafts down. Here's a lima, and so let's go take a look at that. And we got a nice looking lima. So as you would suppose, we like to usually follow it back up the subclavian to the subclavian origin to see if there's a subclavian stenosis. And so we would be looking right there if we were looking for a subclavian stenosis, because you got to follow it all the way back to make sure that, and we do follow it all the way back. Here it is, and there's no subclavian stenosis. So to be thorough when you're exploring a lima, you got to go back there and look. So that means you got to go very high at the junction of 2/3 of the distal clavicle to the distal 1/3. You got to be able to get that high to be able to see this stuff. And so I see no vein grafts that have survived. I see that little dimple up there when they must have inserted a cannula for the heart-lung machine. And all I see is a patent lima, and so big vein back there. But not a very big surprise to us, because you just don't see those things patent in patients when you're going out 12 and 13 and 14 years. Vein grafts are down, and so I think this will be useful in my management of this gentleman, because I'll be exploring his coronaries to see what we're filling and what we're not filling, and what good the vein grafts were. Of course, they close down if you don't have disease in the coronary, and so we know that for sure. And so if you bypass a vessel that has a 60% lesion in it, it's not going to stay patent with the bypass. But we'll have to explore the native vessels here and decide, you know, what this gentleman is going to need from us now that he doesn't have patent grafts. We can go to each one. But the whole thing is getting the information, and is it useful to us, and how can it help us in patient care. So we got one more we're going to show you. We go back to the slides. And saphenous vein grafts are all down. 3 grafts are down, and 1 lima is paid. 78-year-old guy who had bypass grafting 11 years ago. And so we don't have the 60% open. We've got, you know, it looks like 1, 2, 3, 4, 25% open. And then our last case is someone who had an apical lateral MI in 1998. And so that's 18 years ago with follow-up. And this gentleman basically has had some PET scans, CHF at one point late in his course, acute pulmonary emboli at another point, some pulmonary fibrosis, and then RV systolic pressure of 66 millimeters of mercury. And then we offered him the CT, and he said he didn't want to pay the copay. The insurance will pay for it, and that was declined. And we did an echocardiogram later this year, just this year early, in 2016. He has a wall motion abnormality, and so that's a bad sign. And we think that there was a problem with his graft. So we're going to take a look here, and can we get those up from Brandon? And so this gentleman had a GI bleed and a positive troponin, and went to the hospital and was transferred. And now we're seeing they're hunting and pecking for grafts. And there's a lima that's patent. And there it goes. So we've got a patent lima on this gentleman. And we're going to scroll through. Nice looking lima. And there's some collaterals to the circumflex. Filling backwards. Graft down. That was the graft to the right. Left ventricle. Abnormality of the posterior basilar area of the left ventricle. Rima is intact and hasn't been used. Calcification of the right coronary. And so the story is that his grafts are down except for the lima. And he was in big trouble because of a GI bleed, and actually with a combination of ischemia and a GI bleed, and didn't survive. And so the point is that knowing about the grafts ahead of time, we certainly had a hint from the echo that there was something going on in the inferior wall. Knowing about the grafts ahead of time, I think, can be very helpful, and I think is a great way to be able to follow these patients, perhaps maybe picking a point of maybe 10 years and looking at them, since that's a point that we well known. And so just doing that if they're asymptomatic at 10 years, and then considering it earlier if they develop symptoms. So we're going to talk to you about the use of coronary CTA in patients who've had prior bypass grafting. And you can see that because the vessels are so large, it's really easy to see. And you also, they have reduced mobility because they're just sort of sitting there, and usually non-calcified walls. And so we've got an accurate assessment of graft patency that's dramatic. This is the most dramatic thing in imaging, because we got a 95% sensitivity and 100% sensitivity, specificity, and we got a 98% in this particular study and a 97%. And so, hey, you can't lose. You've got that information. I think it's so easy to get. It's economical, and I think it's extremely useful. And so it's not as useful for looking at the vessels themselves, as you see, in terms of sensitivity, accuracy, and specificity. And you saw how we struggled to look at those actual vessels in the patients because they're so calcified, and probably they're CTOs, chronic stable occlusions. But you can see that it's very, very helpful for us to look at it. We have huge accuracy, and so I think there's a good point to doing it prophylactically at 10 years. There's some people, there's a low low-doco study where colchicine was given patients with coronary bypass grafting to try to inhibit inflammatory reactions at 10 years and to see if that prevented late stenosis and occlusion of saphenous vein grafts. Anyway, we don't have enough data on that because there was very few patients. So does anybody have any questions? Hey, Dr. Carroll, any questions about this? Dr. Carroll, for once, is silent. So I hope he finished his strawberries. Thank you, everybody, for coming. It's a pleasure to talk to you. I'm glad you could attend. Janet, Christine, CJ, Robert, Sharon, Teresa, Melody, thank you very much. We'll see you next week. Bye-bye.